Okay, so you know that feeling, right, when you're like really trying to get up to speed on something, maybe for work, maybe just something you're curious about.
Right.
And you need like the core info,
Yeah,
without like drowning in a sea of details.
absolutely.
So that is what we are doing today. We are diving deep into oral pathology,
Okay.
and we're going to focus on like the essential vocabulary and the process of getting oral biopsies.
Right.
And, we've got some great material to help us with this.
Yeah, we do. We've got a really detailed document that goes over a lot of the key terms
Okay.
and the different ways that oral biopsies are done.
Okay.
And then we've got this really interesting audio recording
Yeah.
with a dentist who really stresses, why it is so important to understand this stuff,
Right.
especially if you want to be able to recognize and understand, different things that can go wrong in the mouth.
Exactly. So our goal today is to give you that solid foundation
Yes.
of the language of oral pathology and understand, why we do different biopsy techniques.
I like it.
So think of this as your like fast track, to being comfortable and knowledgeable in this whole area.
Perfect.
And we're going to be pulling from, the written guide on terminology and procedures and that audio discussion with all the important points.
Sounds good.
So let's get started with like the foundation,
Yeah,
the
sure.
terminology.
Absolutely. I mean, you got to understand the terms, right?
Oh.
Like, it's the shared language
Yeah.
that we all use to describe, what we're seeing, and then we can talk about what the diagnosis might be.
Exactly.
So, yeah, without that foundation, it's hard to even have a conversation about this stuff.
Right. So let's jump into that basic terminology document.
Okay.
It's full of really helpful definitions. So we'll start with bulla.
All right.
And it says it's a blister-like lesion bigger than 1 centimeter
Oh, I.
across. And it's got fluid, and it could be serum. It could even be blood.
Okay.
What's significant about that one?
I think the important thing there is the size, right? Because if it's smaller than a centimeter, then we're usually talking about a vesicle, which the document says is like a small fluid-filled blister, less than half a centimeter across.
Okay.
So bulla is like the big version.
Gotcha.
And that's important, right? Because it helps us kind of narrow down what could be going on.
That makes sense. Big blister versus little blister.
Exactly.
Okay, got it. Then we have disquamative,
Ooh.
which refers to the oral epithelium. So that's that surface layer
Right.
slowing off because it's separating from the submucosa, so the tissue underneath.
Yeah, it's almost like when your skin peels after a sunburn,
Right, right.
but it's happening inside the mouth.
Exactly. Why is that important to recognize?
Well, I mean, recognizing that pattern, where the tissue's kind of shedding like that,
Yeah.
can point us to like a certain category of conditions,
Okay.
often ones that have like an immune system component to them.
Oh, interesting.
So it helps us, tell that apart from other kinds of lesions like ulcers or, growths.
Okay, yeah, that makes sense. All right. Ecchymosis.
Now there's a word.
I know, right? It sounds kind of technical, but it's basically just a bruise.
Okay.
But in the mouth specifically, it's submucosal hemorrhage that's bigger than 2 centimeters.
Okay.
And the document says it usually comes from some kind of trauma, so like bigger than just a little spot of bleeding.
Right, exactly. And that size, helps us tell it apart from like petechiae, which are these tiny pinpoint hemorrhages.
Okay.
And, knowing that there was some trauma
Yeah.
is a really important piece of information when we're trying to figure out if it's ecchymosis or not.
Right. Okay. Makes sense. Endophytic.
Right.
So this is a lesion that grows inward,
Okay.
extending into the deeper tissues.
Interesting.
And a key thing here is that it's usually indurated, which means it feels firm or hard when you touch it.
I see.
So what does that inward growth and that firmness suggest?
Yeah, that can be a little concerning sometimes,
Okay.
because it can mean that there's something more aggressive going on,
Wow.
like it's infiltrating into the surrounding tissues.
Wow.
And that firmness, helps us tell it apart from lesions that are like softer, more superficial.
Okay, that makes sense. Growing in and feeling hard, definitely something to keep an eye on.
For sure.
All right, so kind of the opposite of that is exophytic,
Okay.
which is a lesion that grows outward, from the surface, so it's sticking out into the mouth.
Gotcha. So you can actually see it.
Right, exactly. And, while it might be more obvious visually just because it's sticking out,
Yeah.
that outward growth doesn't necessarily tell us, if it's benign or something more serious.
Right.
So we might need to do some more investigating.
Except.
Okay. Erosion. So this is when the surface layer, the epithelium, gets thin. And it often looks red, or what they call erythematous.
Oh, okay.
And the document also says that erythematous itself just means red. And that redness could be because of the thinning, from the erosion.
Right.
But it could also just be from, more blood flow to the area for other reasons.
Like inflammation, maybe?
Exactly. So erosion can cause redness, but redness doesn't always mean erosion.
Exactly. You got it.
Okay, so red doesn't always equal erosion.
Yep.
Got it. You mentioned indurated earlier.
Yeah.
And the document just defines it very simply as, firm when you palpate it. But you said it was an important clinical sign, so why?
Well, you know how firm a lesion can give us some clues about what it's made of,
Okay.
and how it's interacting with the tissues around it.
Okay.
Like, some tumors or like chronic inflammation can cause the tissue to get really hard.
Oh, okay. That makes sense.
Yeah.
Keratinized. So this is that white patch that you can't just wipe away.
Oh, right.
Because it's from a buildup of keratin on the surface, like a callus on your hand.
Yeah, exactly.
So why is that significant that it's non-removable?
Well, because that helps us tell it apart from other white things you might see in the mouth.
Yeah. Okay.
Like thrush, which is a yeast infection that often looks like a white coating, but you can wipe it off.
Yeah.
A true keratinized lesion, though, is different.
Okay.
It means there's been like a real change in the structure of the tissue.
So it's not just something sitting on top.
Right, exactly.
Okay, Mkulia. This is a flat lesion that's well-defined.
Okay.
And the key here is that it's pigmented.
Oh, so it has color.
Yeah, it's a different color than the surrounding mucosa.
Like a freckle.
Exactly.
Okay.
Neoplasm.
Right.
This is a pretty broad term.
Yeah.
Basically just means an abnormal new growth of tissue. And of course, as we know, it could be benign or it could be malignant.
Right.
Nodule. So this one is described as an elevated, well-defined lesion. And you were saying earlier that it's like bigger and more substantial than a papule.
Yes, exactly.
Which we'll get to in a minute.
Okay.
So a nodule is something you can see and feel like a lump.
Yes, exactly. It has like 3 dimensions. You can feel that it's raised, and you can feel the edges of it.
Okay.
And the size and how it feels,
Yeah.
Can give us more clues about what it might be.
Right. All right. Papillary.
Ooh, that one.
I know, right? It describes a surface that has a lot of these like blunted projections.
Oh, I always think of it like a cauliflower.
Yes.
Exactly.
It's bumpy.
So what kind of conditions could look like that?
Well, you can see a papillary surface in a lot of different things,
Okay.
benign things, pre-malignant things, and even malignant things sometimes.
Wow.
But that bumpy texture, it's a key thing that pathologists look for when they're examining the tissue.
Oh, okay. Interesting. Papule, so this one is a slightly elevated solid lesion, and it's also well-defined.
So it's raised but not as big as a nodule.
Right, exactly.
Okay.
Pedunculated.
Okay.
This describes how a lesion is attached, and specifically it's attached by a narrow stalk, like a mushroom.
Exactly. So why is that significant that it's got that stalk?
Well, because of that narrow base, it often makes it easier to remove surgically.
Okay.
And that stalk can sometimes give us clues about where the lesion came from and how it grew.
Oh, interesting. All right, so the opposite of that is sessile.
Right.
Where it's attached by a broad base, so it's just sitting right on the tissue.
Okay, so no stalk.
No stalk.
Gotcha.
Does that broad base make a difference?
It can sometimes, a sessile lesion can be harder to remove completely.
Oh, okay.
Because it's like really rooted in there.
Right.
So that's another thing clinicians think about when they're trying to figure out what to do.
It's more integrated with the surrounding tissue.
Exactly.
Got it. Petechiae. So these are those tiny little hemorrhages appearing as multiple small red spots.
Yeah. What causes those?
Well, it could be a lot of things, actually.
Okay.
Trauma, certain medications, even some underlying conditions that affect blood clotting. But the key is that it's multiple little spots.
Gotcha.
Okay, pseudomembrane.
All right.
So this is a non-adherent kind of whitish to yellowish covering that forms on an ulcer. And it's made up of necrotic debris, so basically dead tissue.
So it's like a protective layer, but not a healthy one.
Right, exactly. It's a sign that the tissue has broken down and ulcerated. And because it's not adherent, you can usually wipe it away.
Oh, okay.
And see the ulcer underneath.
I see.
Okay, speaking of which, an ulcer is defined as a localized area where there's complete loss of that surface layer.
Right, the epithelium.
Exactly like a canker sore.
Yeah.
So that lining is gone, exposing the deeper tissues, which is why they can be so painful.
Yeah, because you've lost that protective layer.
Right.
And that makes it really sensitive and, prone to getting infected.
Exactly. Okay, we're getting through these verrucas.
Okay.
So this one describes a surface with lots of these long projections.
I remember this one you said, think of like a wart.
Exactly.
Yeah.
So is that like the key feature, those long projections?
Yeah, they give it that rough, warty look,
Uh-huh.
And that specific appearance can help us identify certain types of lesions.
Interesting. We already covered vesicle, that little fluid-filled blister.
Right, the small one.
Okay, so that was a really good rundown of all those terms.
A lot of terms.
I know, right? But the audio recording talked about this too.
Huh.
But it kind of framed it differently in terms of primary and secondary lesions.
Oh, yeah.
So how does that perspective help us understand all this?
Well, the speaker in the audio was saying that a lot of those terms we just went over
Yeah.
describe like the initial presentation, the primary lesion.
Oh, okay.
And they specifically mentioned, maculopapule.
Mm-hmm.
And then they said that a nodule or tumor is basically just a bigger or deeper version of a papule.
Okay.
And then plaque, and they said a wheal, like when you have an allergic reaction, is a type of plaque because it's that temporary swelling.
Oh, okay.
Then vesicle and bulla, the big one.
Right. And then pustule, which is like a bulla, but it's got pus in it instead of clear fluid.
Okay.
So thinking about it in terms of primary lesions helps us kind of categorize those initial changes that we see.
So these are the first things you see or feel.
Exactly.
Got it. Okay. And then the audio went on to explain secondary lesions.
Right.
Which is like what happens to those primary lesions, as they change over time. Or maybe because of something else like scratching or an infection.
Yeah, like they evolve.
Exactly. So can you give us some examples of how those primary lesions might change?
Sure. So they talked about scales, like when the outermost layer of skin flakes off after a blister dries up.
Oh, okay.
Crust, which is like dried fluid or pus on the surface.
Yeah.
Maybe from a vesicle that's ruptured.
Okay.
A fissure, which is a crack or groove.
Uh-huh.
And then ulcer, which we talked about as a primary lesion.
Right.
But it can also be secondary, like if a vesicle or bulla breaks down, it can turn into an ulcer.
And the audio really emphasized that an ulcer as a secondary lesion still involves that loss of the epithelium,
Right.
Exposing the connective tissue underneath.
Ouch.
Yeah.
And then there's a scar, which is how the body tries to repair that damage after an ulcer heals.
Mm-hmm.
And often you end up with too much collagen.
Right.
Atrophy. So this is like a thinning of the epithelium.
Okay.
But the connective tissue isn't exposed yet. So it could be like a warning sign.
Right.
That something worse might happen if you don't take care of the problem.
Absolutely.
So it's really interesting how this whole idea of primary and secondary lesions helps clinicians track what's going on.
Yeah, it's like timeline.
Exactly.
By describing the initial appearance and then any changes, we get a better picture of the whole process.
Right.
And that helps us figure out the right diagnosis and the best way to treat it.
Makes sense. So whether we're talking about specific terms or categorizing them as primary and secondary,
right,
both our sources are telling us that understanding this basic vocabulary is like the key
absolutely
to understanding oral pathology.
It's how we communicate,
Correct.
clearly and accurately.
Okay, so now that we have that foundation, let's move on to a really crucial part of this whole thing. Biopsies.
Okay, biopsies, yeah.
So when and why do we take a tissue sample?
Well, oral biopsies are like essential, for diagnosing a lot of oral conditions. And in some cases, the biopsy itself can actually be the treatment.
Oh, wow.
But basically, it's a surgical procedure where we take a little piece of tissue from a living person, and then we look at it under a microscope to see what's going on.
And the document gives a very clear definition. It says it's a surgical procedure to get tissue from a living organism for microscopic examination, usually to make a diagnosis or sometimes as a treatment itself.
Right. And the audio recording really emphasized how important biopsies are for getting that definitive answer, like what's happening at the cellular level.
Right, because you can't always tell just by looking.
Exactly.
Okay, so to really understand why biopsies are so important, let's talk about the objectives. Like what are we trying to achieve when we do an oral biopsy?
Right.
And the document lays out several key goals.
Right.
The first one, and maybe the most important, is that it lets us define the lesion based on its histopathological appearance.
Okay.
So what the cells look like under the microscope.
That's the gold standard.
Exactly.
That's how we really know what we're dealing with.
Right. The second goal is establishing a prognosis, especially for lesions that might be cancerous or precancerous.
Okay.
Third, the biopsy results tell us how to treat it.
Makes sense.
And fourth, if treatment has already been given, a follow-up biopsy can tell us how well it's working.
Oh, right. To check if it's effective.
Exactly. And finally, the biopsy report is like a legal document.
Oh, yeah.
It's proof of what was found.
Right. That can be important.
Absolutely. So those objectives really show just how much info we can get from looking at tissue under a microscope.
It's amazing.
It is. Okay, so when is an oral biopsy actually indicated? Like, when do we know we need to do it?
Right.
Both of our sources give us some pretty clear guidelines.
Okay, good.
So one of the main reasons is to confirm if a lesion is malignant, to diagnose it.
Right.
And also for precancerous conditions like leukoplakias.
Those white patches.
Exactly. Or the erythroplakias, which are the red patches.
Okay.
If they can't be explained by something else.
Yeah.
Another reason is for any chronic ulcer that just won't heal.
Right.
And we don't know why. And the audio recording gives this really practical example.
Okay.
They said if someone has an ulcer that looks like it's just from inflammation, but it doesn't get better within 2 weeks after you've removed any possible irritants.
Like a sharp edge on a tooth or something.
Exactly.
Yeah.
Then you definitely need to do a biopsy.
That makes sense. 2 weeks seems reasonable.
Yeah. The document also mentions lesions that are interfering with normal function.
Oh, okay.
Like those fibrous hyperplasias or bony growths.
Right. Even if they're benign, they can cause problems.
Exactly.
Yeah.
And a biopsy might be part of the treatment in those cases.
Okay.
And another really important indication is any lesion where we just don't know what's causing it.
Especially if there are symptoms.
Right, especially if it's painful or numb or if there's a weird taste or sensation.
Yeah, those are red flags.
Exactly. We need to figure out what's going on.
Definitely.
And the audio specifically said that any unexplained red or white patches really need to be biopsied.
Because they could be something serious.
Exactly. They could be early signs of something worse.
Okay. That's good to know.
And the document also mentions interstitial lesions. So those are the ones that are within the muscles of the tongue, cheek, or lip.
Interesting.
And any lesions that show up on x-rays?
Oh, yeah. The radiolucent or radio-opaque ones?
Exactly. And the audio really stressed how important it is to biopsy those.
Yeah, because they can indicate a lot of different things.
Right. Some of which might need urgent attention.
Okay. So we've talked about when you definitely need a biopsy. What about when you don't?
Yeah. Are there times when it's not necessary?
Well, both sources talk about that too.
Good.
So, for example, normal anatomical structures.
Okay.
Like the torus palatinus or torus mandibularis.
Those bony bumps.
Yeah, exactly. Those usually don't need to be biopsied.
Okay.
And also, if you have an ulcer that's clearly caused by something, like a sharp edge, and it heals after you smooth it out, you don't need to biopsy that.
Makes sense if you know the cause and it goes away.
Right.
No need to do anything more.
Exactly.
The document also says that inflammatory or infectious things that respond well to treatment, like pericoronitis.
Around a wisdom tooth?
Yeah, gingivitis, periodontal abscesses.
Right. Those are usually pretty straightforward.
Exactly. But the audio made a really important distinction.
Oh, okay. What's that?
They said if you're monitoring how a neoplasm is responding to treatment, you might still need to do a biopsy to see how well it's working.
That makes sense. You want to know if the treatment is effective.
Right. And the document also says that you generally avoid incisional biopsies on suspected angiomatous lesions.
Angiomatous.
Yeah, which are basically lesions made up of blood vessels.
Oh, okay.
Because there's a risk of bleeding.
Yeah, that makes sense. You don't want to cause a hemorrhage.
Exactly. Okay, so we've talked about when we need a biopsy and when we don't.
Yeah.
Now let's dive into the different types of biopsies.
Okay, there are a few different ways to do it, right?
Right. The document lists 4 main techniques.
All right, let's hear them.
So we have incisional biopsy, excisional biopsy, brush biopsy, which is also called exfoliative cytology.
Okay.
And fine needle aspiration biopsy.
Wow, that's a mouthful.
I know, right? But each one has its own advantages and is used for different situations.
Okay, so let's break them down.
All right, let's start with incisional biopsy. So how does that work? Okay.
And when would you choose to do that?
All right.
So the document describes it as taking a sample of the lesion and some of the normal tissue next to it
Okay.
to get a diagnosis before you do any treatment.
Right.
And the audio actually showed a diagram of this.
Oh,
It
cool.
was like a V-shaped wedge being taken out.
I see.
And they explained that including the normal tissue
Yeah.
helps the pathologist compare it to the abnormal area.
That makes sense.
And both sources agree that you have to do this type of biopsy if you think it might be cancer.
Okay, so why is that normal tissue so important?
Well, it's like a control for the pathologist,
Oh, okay.
so they can see how the normal cells transition into the abnormal cells.
Uh-huh.
And that helps them make an accurate diagnosis.
And figure out how far it spread.
Exactly. Okay,
Yeah.
so excisional biopsy sounds different. How
Yeah.
does that one work?
So with excisional biopsy, you remove the entire lesion.
The whole thing?
So it's both diagnosis and treatment at the same time.
The audio said this is a good option for lesions that seem benign
Okay.
and where you can get it all out with a margin of healthy tissue,
Mm-hmm.
like a fibroma or a pyogenic granuloma.
Okay.
In those cases, removing it is the treatment.
Got it.
But they said you shouldn't do an excisional biopsy if you think it might be malignant.
Why not?
Well, because if it turns out to be cancer,
Yeah.
you might not have taken out enough tissue.
Oh, okay.
You might need to go back and remove more.
To make sure you got it all.
Exactly.
So it's better to do an incisional biopsy first.
Yes.
Get the diagnosis and then plan the surgery accordingly.
Makes sense.
Okay, brush biopsy or exfoliative cytology.
Right.
This one uses a little brush to collect cells from the surface.
Uh-huh.
So how does this compare to the surgical biopsies?
Well, the audio said it's much less invasive.
Okay.
You usually don't even need anesthetic.
Wow.
And it's quick and easy to do.
That's good.
And it's really helpful for certain infections,
Like what?
like candida infection.
Yeast infections.
Exactly. You can see the fungal hyphae under the microscope.
Wow.
The document also mentioned it's good for diagnosing other infectious and non-infectious diseases
Okay.
that affect the surface layers.
So it's good for surface stuff,
Yeah.
but might not be enough for deeper lesions.
Right. It doesn't give you the full picture.
Okay, and finally, fine needle aspiration biopsy.
Okay.
This is used for specific areas like salivary glands and lymph nodes,
Right.
and you use a thin needle to draw out cells or fluid.
Uh-huh. What kind of information could you get from that?
Well, the audio explained that usually the patient rinses with an antiseptic mouthwash first,
Okay.
and you might use a local anesthetic.
Uh-huh.
Then you take a really thin needle,
Okay.
usually 22 gauge.
Wow, that's tiny.
I know, right? And you stick it into the mass
Okay.
and aspirate some cells or fluid,
Hmm.
and then you look at it under a microscope.
And that tells you?
Well, it can help you tell if it's benign or malignant,
Oh, wow.
or if it's just inflammation.
So it's a good way to get a preliminary diagnosis.
Oh.
Yes, exactly.
Okay, so each type of biopsy has its own purpose.
Right.
And you choose the right one depending on the situation.
Exactly. Now, regardless of which type you do, there are some key things about the technique itself
Mm-hmm.
that are really important.
Yeah, like what?
Well, the document says that using a regional nerve block for anesthesia is better
Oh,
than injecting the anesthetic directly into the lesion.
why is that?
Well, the audio explained that injecting it directly can distort the tissue
Oh, I see.
with the anesthetic fluid,
Yeah.
and that can mess up the diagnosis.
Right.
So a regional block numbs the area
Uh-huh.
without changing the tissue itself.
That's smart.
Yeah, and the document also recommends that if you're making an incision,
Okay.
you should make it elliptical
Elliptical, why?
because it's easier to suture closed.
Oh, that makes sense.
And you should make the incisions parallel to any major nerves and blood vessels
Yeah.
so you don't damage them.
Good idea.
And for small lesions, less than a centimeter. You can usually just do an excisional biopsy.
Take the whole thing out.
Yep. But for larger lesions,
What?
you usually do an incisional biopsy and take samples from different areas.
Sure.
And you always include some healthy tissue at the margins.
Right.
And as we discussed earlier, if you think it might be cancer,
Yeah.
incisional biopsy is a must.
Got it.
So basically, we want to get a good sample
Yeah.
without hurting the patient too much
Right.
and make sure it heals properly.
Very important.
Okay, so once you've got that tissue sample,
Yeah.
how you handle it right afterwards is crucial.
Oh, yeah. You don't want to mess it up.
Exactly. The document says you need to orient the specimen properly.
Yeah.
Sometimes you put a little suture in a specific spot
Mm-hmm.
or use a tiny piece of paper to mark it,
Okay.
and then you immediately put it in a container with a fixing solution,
Right.
usually 10% formalin.
Formalin with it.
It's a chemical that preserves the tissue.
Oh, okay.
And the audio really emphasized handling the tissue gently.
Yeah, you don't want to crush it or anything.
Exactly. They even said to put a piece of paper between the tweezers and the tissue
Why?
when you're moving it.
That's being careful.
I know, right? So why is that immediate fixation so important?
Well, it basically freezes the tissue in time.
Oh, okay.
So it doesn't start to break down or change.
Which could mess up the diagnosis.
Exactly.
And orienting it properly tells the pathologist how it was positioned in the mouth.
Right. So they know what they're looking at.
Exactly. Okay, so the number of biopsies and where you take them from
Yeah.
depends on what the lesion looks like.
Okay.
So if a lesion has different looking areas,